Hello and welcome to this American Society of Nuclear Cardiology three-part CME webinar on interpreting and reporting F-18 Flurpiridaz PAT-MPI studies. I'm Muaz Al-Mallah from Houston Methodist Hospital, and it is very exciting time for nuclear cardiology. F-18 is the first new radio tracer for PET myocardial perfusion imaging in almost 3 decades. The three-part webinar series, funded by an unrestricted education grant from GE Healthcare, is based on two reader training sessions held earlier this year, where cases were read from my computer and two different software approaches were utilized to analyze the studies. You will hear from faculty who participated in both sessions, and they will provide their experience and expertise on acquisition, interpretation, and reporting of myocardial perfusion imaging studies with F-18 Flurpiridaz. There is discussion on physiologic uptake patterns, incidental findings, and many clinical pearls to help you as you incorporate this new radiotracer in your laboratory. Most of these cases come from the phase 3 clinical trials with two real-world cases presentations in part 3 of the series. The first part provides an overview of F-18 Flurpiridaz and discusses interpretation of normal studies performed with pharmacologic stress and provides important perspective on the added value of myocardial blood flow. The second and third segments will delve into more challenging cases as well as the use of exercise testing and experience with this tracer in a real-world setting. Dr. Panitha Shirintiwati is the co-chair of the program, and we have an esteemed faculty to guide you through the series. The faculty includes Dr. Tim Bateman from St. Luke Mid-America Heart Institute in Kansas City, Missouri, Dr. James Case from Cardiovascular Imaging Technologies, also in Kansas City, Dr. Rob DeCamp from University of Ottawa Heart Institute in Ottawa, Canada, Dr. Marcelo DiCarli from Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts, Dr. Jamshid Madahi from UCLA in Los Angeles, Dr. Piotr Slomka from Cedars-Sinai Medical Center, Los Angeles, and Dr. Jennifer Raynaud from Invia in Michigan, as well as Dr. Prem Soman from University of Pittsburgh Medical School. Here are the faculty disclosures for our 3 sessions. And for each case, the faculty will discuss uptake patterns, incidental findings, and normal variants seen with F-18 radiotracers and how they differ from existing cardiac PET tracers. We will use a systematic approach to review these images and finally look how these PET MPI cases will help you serve your patients with the clinical information you need to convey to your referring physicians. At the end of each program, there is a link you can use to claim your CME. You will need to complete an evaluation before claiming credit. Let's get started. It's my pleasure to introduce Dr. Panitha Shirintiwati, who will provide an overview of F-18 Flurpiridaz.
Thank you so much, Moaz. So as Dr. Almala mentioned, after more than 20 years without a new FDA-approved perfusion tracer, we now have F-18 Flurpiridaz. So it's an exciting development with the potential to broaden access to cardiac PET and enhance diagnostic capabilities. So this really marks a notable evolution in nuclear cardiology, and I'm really proud that ASNC is helping lead the effort to bring this innovation into clinical practice. So as Dr. Almala mentioned, tonight's session will focus on image interpretation And this is an essential step now that the tracer is available. And again, this is just the beginning because ASNC will continue to provide practical tools, educational programs, and clinical guidance to support successful implementation of the tracer across diverse practice settings. So we have a stellar panel of experts with us this evening, and I'm confident their insights will be both practical and really impactful. And so before we dive into the images, I'd like to take just about 8 minutes to provide you with an overview of the unique properties of F-18 flurpiridaz and the protocols associated with its use. And this is the structure of F-18 flurpiridaz. It's derived from the pesticide paraben. It works by binding to mitochondrial complex 1 in the heart. Now, flurpiridaz has several favorable characteristics. First, it has very high first pass extraction fraction, over 90%. And this has various benefits, including the ability to identify milder perfusion defects and greater accuracy in reflecting the true extent of defects as compared to technetium-labeled tracers. And so F-18 flurpiridaz also has a linear relationship between tracer uptake and myocardial blood flow, with a strong correlation with radioactive microspheres in determining absolute quantification of regional myocardial blood flow over a wide range of flows. There's very little roll-off phenomenon at high flows as shown here, and this promotes not only accurate flow quantification, but also less underestimation of ischemia. Flurpiridaz also has the shortest positron range among the commonly used PET perfusion tracers at 0.1 millimeter in tissue. And a shorter positron range is better for both image quality and flow quantification. It also has the longest physical half-life at 110 minutes among the commonly used PET perfusion tracers. So all of these favorable characteristics of flurpiridaz, the high extraction fraction, linearity with flow, short positron range, and long physical half-life all contribute to several advantages. And this is particularly true for superior image quality. So you have higher count statistics, high spatial and contrast resolution, greater defect resolution as compared to SPECT, and we'll go over some of these defects and reversibility are more readily identified, and so there's greater interpretive certainty. And in terms of diagnostic accuracy, in the Aurora trial, the phase 3 part 2 study that led to FDA approval of flurpiridaz for overall detection of epicardial CAD, that's defined by 50% stenosis, sensitivity and specificity of flurpiridaz PET were significantly higher than the pre-specified threshold. Sensitivity was also higher for flurpiridaz PET than SPECT. And this is in all comers, in women, and in those with BMI greater than 30. At the same time, specificity was non-inferior between flurpiridaz PET and SPECT MPI. Then operationally, the longer physical half-life of flurpiridaz of 110 minutes has the advantage of facilitating availability of the tracer for unit dose distribution from regional radiopharmacies so that practices don't need higher cardiac PET volumes to be economically viable. They also don't need an on-site cyclotron since the tracer can be shipped from outside facilities. There's also the advantage that flurpiridaz can be combined with exercise treadmill stress because of the longer physical half-life. But with exercise, we will lose flow. We also need to acknowledge some of the current opportunities or challenges with flurpiridaz. Because it's a new tracer, clinical experience is still relatively limited, but this is rapidly changing with at least 30 sites expected to come on board soon. There are new imaging patterns we'll need to become familiar with, and we will go over these. I've listed them, but we will go over these throughout this session. We also need to be cautious about overcalling subtle defects given the changes in image appearance and that milder defects may appear. On the more practical side, flurpiridaz is associated with a somewhat higher radiation dose compared to other PET perfusion tracers. perhaps higher per patient costs, and the availability initially may be a little bit limited. And then currently, the protocols are less efficient, but there are efforts underway to streamline acquisition and improve efficiency. So stay tuned for that. So, speaking of protocols, here is the pharmacologic 1-day rest stress flurpiridaz PET CT protocol that was used in the phase 3 part 2 or Aurora trial. And so this is what's in the package insert. And following the CT scout and transmission acquisitions, 2.5 to 3 millicuries of flurpiridaz is injected, and a single ECG gated 15-minute dynamic list mode acquisition can be performed. And then after the resting acquisition is completed, we can get ready for the stress, but we need to wait at least 30 minutes between the rest and stress tracer injections for pharmacologic stress. 30 minutes. Once the appropriate time has passed, we can then give the vasodilator stress and then 6 to 6.5 millicuries of flurpiridaz, and then another 15-minute ECG-gated dynamic list mode acquisition is performed. So the total time is about 1 hour, but we need to wait that 30 minutes. Again, there are efforts to shorten and make the protocol more efficient. A couple of additional key points. The total activity should not exceed 14 millicuries for an individual subject. And flurpiridaz and adenosine should be given through separate lines or separate ports of the same IV line. The rest I've already mentioned. The 1-day exercise flurpiridaz protocol takes slightly longer because with exercise, the rest and stress tracer injections need to be at least 60 minutes apart. And then the image acquisition will also, for stress, it will need to start 15 to 25 minutes after stress injection. So we have to time this. And again, we cannot currently measure myocardial blood flow with exercise treadmill PET, but several groups are working on testing more efficient protocols and also maybe trying to estimate flow without the initial bolus injection. Also remember that during exercise, the patient should continue to exercise for an additional 1 to 2 minutes after the flurpiridaz injection as much as possible. So when Dr. Almala will start to show us normal F-18 flurpiridaz images, you will see the following. First, the LV myocardium will be better defined than what we're used to seeing with SPECT MPI and with rubidium. Images may look a little bit more like N13 ammonia images if you use N13 ammonia. The myocardium will appear thinner and the LV cavity will appear larger. Second, the count distribution will be more homogeneous, but there could be some subtle defects that we need to be careful not to overcall. Papillary muscles are often visible. We see them more with rest than stress. And then anatomical apical thinning is present in most cases. Dr. Almala will show you examples. This is very important. Subdiaphragmatic activity may be present, but usually does not interfere with interpretation. RV uptake is often present in normal flurpiridaz images. And then there's usually clear segmental brightening and excursion on normal gated flurpiridaz images. For abnormal flurpiridaz images, defects are more evident and reversibility more readily identified with higher interpretive certainty. And with pharmacologic stress, the EF and wall motion may decrease with stress in abnormal studies. TID may be more evident with flurpiridaz, but currently we do not know the TID ratio threshold to use. This is also being worked on. And then the effects of misregistration or motion may be more pronounced. And so now I'm going to turn it back over to Moaz to show us some flurpiridaz images. Thank you very
Thanks,
much.
Benithia. And we're going to start with the first case, and our panelists are going to start to help us look at these cases. So the first case, the patient is a 51-year-old lady with a BMI of 27, and she's coming in with chest pain, non-diabetic, hypertensive, and dyslipidemic. And Maybe we can ask Dr. DiCarli to start with in terms of quality assurances once we start with the images, like in PET in general. What do you look first at? Do you start with the fusion? What quality assurance measures do you want to look at?
Well, thank you, Moaz and Panithia. So, when we read PET-CT, we'd like to start with some quality control. And I guess the basic quality control measure that we want to perform is to ensure that the PET perfusion study and it's well aligned with the corresponding CT. To ensure that the attenuation correction will be done properly and that there will not be any artifacts on the images. And so what you do is you scroll through the images and make sure that essentially the color picture fits well within the gray picture of the cardiac silhouette, like you see on this particular scan. You want to do this for the rest and also for the stress images. In this case, I guess we have the stress images. You want to do the same exercise then for the rest images. So yeah, and you see it here, perhaps a little bit of a misalignment there in the apical portion of the heart. You can see the lung shadow overlapping a little bit on the myocardium, suggesting that there may be some misregistration. Not all misregistrations will lead to artifacts or to defects. So minor misregistration will likely not cause any problems, but you want to be aware of this because you definitely don't want to overcall defects that are in fact artifacts. If you do see gross misregistration, you will not be able to fix it at the computer where you're reviewing the images. The images have to be manually or automatically realigned at the console of the scanner and reconstructed again to make sure that they're properly aligned.
Thanks, Marcelo. Is there a limit to how much misregistration, like, would you accept and not accept? Ideally, we don't want any, but do you think this is going to be concerning, not concerning? Jennifer, if you want to take this one,
Sure.
how much, I know Marcelo alluded to it a little bit.
Yeah, so here the misregistration is only on a few frames, and it's not too far out, so I would say it's affecting the image somewhat, but I wouldn't say that now it's become a non-usable image. I mean, rule of thumb is that you want to have the PET-CT activity at the 50% level within the CT threshold. So obviously this falls somewhat outside of that. But we would have to look at, if you look at the perfusion images to see if there's an actual misregistration artifact. Sometimes it could also be just an issue on the display. If the transformation coordinates are not correct, potentially we're getting just a problem in the display with the alignment.
All right, thank you. All right, Dr. Madahi, how can we look together at this image and help interpret it?
Yeah, right off the bat, for those people who have been doing SPECT imaging or doing rubidium PET, you will see that what is striking is that the myocardium is thinner, the cavity is much better defined. We often, I would say most of the cases, we do see right ventricular activity, which is not an abnormal finding because of a higher resolution. Visualization of the right ventricle is quite normal with Flurpiridaz. The second feature that we notice is that the myocardium is activity is quite uniform throughout the left ventricular myocardium. Again, as opposed to SPECT, you can see that the pattern of inferior wall attenuation is not seen as a result of routine attenuation correction with this tracer. Another feature that you notice is that in some of the cases, you can actually see the papillary muscle. Here you can see on the resting study, the papillary muscle, and also on the stress study. We were quite excited when we saw our first few cases that we could see papillary muscle. We were quite excited that if we don't see on the stress, but we see it on the rest, that would be an index of ischemia. But after more experience, we realized that we cannot rely on that. So I would not interpret anything into the visualization or lack of visualization of the papillary muscle in these cases. Then when you look at the vertical long axis and horizontal long axis slices, you'll see that as we approach the apex, the myocardium gets thinner and there is less activity. This is not evident generally with SPECT or with rubidium PET because of the differences in the image characteristics and in the spatial resolution. Here we have the best spatial resolution, and this type of a pattern is apical thinning. And the way we can confirm that is that we see often no change from stress to rest. And also we can look at two other ways of differentiating it from scar tissue. One is to look at the gated study that you will see that the apex actually is thickening normally. And or you can compare the end diastolic and end systolic images, and you can see again evidence of thickening and increased counts in the apex. So that would be very important. Now, I would like to, I think that Dr. Al-Malai is going to go to the gated studies. I will wait until we take a look at that and come back. I want to make a few more comments on the quality of the images. So here you can see that this apical thinning on the short horizontal long axis and vertical long axis slices, you can clearly see thickening of the apex or increased counts in the region of the apex. That is indication of normal apical thinning in this individual. Now, going back on the non-gated images, I wanted to point out the characteristics of the background. That is a very important feature of Flurpiridaz, that we often see. What you see here is a pretty characteristics. I would say that like probably 80-85% of patients will show some background activity that does not interfere with the myocardium. So in general, we have a high myocardial to background ratio, and this ratio is the best on exercise images. On the exercise images that we will be seeing later, you will see that actually you have virtually no background activity, and that actually is a very important feature of this tracer with a high myocardial to background ratio. And I think that aside from this, these comments, I would also point out that we have to be very sensitive to not calling the ventricle dilated. We are sort of used to seeing when we see the cavity of the ventricle to the extent that we see here, we tend to interpret it on SPECT images as LV enlargement, but this is not LV enlargement. It is purely related to the higher resolution of this tracer.
So, Jamshid, are there any numbers that you have been using, at least in your prior studies, to call, or we're just gonna extrapolate from our rubidium numbers? Where do you think
Yes,
were the numbers?
we haven't established a normal limit for the ventricular cavity or the ventricular volume. In one publication, the number that I think that part of the problem is that, as you know, the size of the left ventricle or the volume of the ventricle depends on the patient's body surface area. And therefore, the numbers have to be established based on the patient's size. In one publication by Dr. Packer from our group, we looked at what differentiates large versus small ventricle, and we used a cutoff of 130 ml of LV as the median number. But I would say that it is something that we have to provide for every, perhaps it could become part of the automated program that could actually compare to the patient's body surface area and indicate whether it is outside the limit.
About this volumes, I wanted to add a comment because we actually tested it a little bit and we found that the filtering affects tremendously the volume size. So I think we have to pay particular attention to the reconstruction parameters as we establish those normal thresholds for volumes, for example, the Gaussian filtering and so forth.
An important point. Panithia, do you want to add anything?
Yeah, so far I've been trying to summarize a few things, but I just want to make some important points that have been said already. One, the left ventricular myocardium looks very well defined, appears thinner, so the LV cavity looks bigger. It's normal. Two, the count distribution is more homogeneous. Three, papillary muscles are often visible, and more so at rest than with stress. We don't make too much of that. It doesn't mean there's ischemia or anything. And then four, a very important point, anatomical apical thinning is present in almost all cases. And we must be very careful not to call this as abnormal. RV uptake, 5, RV uptake is often present. 6, subdiaphragmatic activity may be present, as you can see here, but it rarely interferes with interpretation.
And I would like to highlight in 1 second just one thing about the apical thinning. So yes, I mean the apex will look thinner. If I zoom on it a little bit, you can see it there, but if you put your gated, you should not see this kind of, you'll see abnormal contraction. So this is, as we were looking at many of these studies, we found that this is pretty common, and we don't want everyone to ensure that they've managed to see it well. So I'm gonna zoom
one
on
comment
it.
was on this. If you see reversibility in the apex,
Yes.
you cannot assume that is a normal variant of apical thinning, because apical thinning will typically be similar on both the stress and the rest images. So be alert to whether there is reversibility in the apex to see if it's truly a perfusion defect or it's just a partial volume effect.
Right, and I cannot help it, Marcelo. I saw a comment about splenic switch off. Yes, you can see the spleen here. It looks well switched off, and I don't know what kind of, I think this was adenosine, so less controversial, but yeah, appears to be adequate response. So we looked at static and gated. We're gonna move on to the dynamics. So these are the dynamics of this patient. And Marcelo, again, as you've done in the first one, can you walk us through the quality assurances in general for blood flow? And then we can talk about nuances for Flurpiridaz.
Well, thank you, Moaz. Okay, so there are a few things that we want to do. Number one is try to ensure that we have a good handle on patient motion, particularly in the early frames when patients are a little more restless because of the pharmacological stress. So you can do this using what Moaz is doing now, which is viewing a cine display of the various frames across time, or you can stop the gating, you can stop the cine loop, and you can do it frame by frame, whatever you prefer, but you need to ensure that there's proper alignment or proper correction of patient motion. One typical thing that we do in this particular software, you can use a visual display, which is here. It's called the LV spillover map, which will essentially tell you visually whether there was significant patient motion, particularly in the early frames, where the blood pool activity may be contaminating the myocardium, and you will see it particularly in the septum or the inferior wall, depending on the motion, and you will see high activity. In this particular spillover map, you see that the spillover is very low, it's almost dark and dark blue, which is very, very low here. But this is something that you want to be aware, because it will affect your blood flows. And then you want to ensure that your input function, which is the green box that you see in the at the interface between the LV and the left atrium. One thing that is always helpful is to, or I found helpful, is to unzoom the images a little bit so you can see the entire part of the left atrium. Moaz, if you could unzoom, if you could stop the gating and do a little bit of a frame by frame so that people can appreciate. In this particular case, the frames are too long, so it flies through the left atrium. But this will allow you to see the entire left atrium, perhaps reposition the green box, which is your input function, if necessary. What you want to see is that the input function should be this green curve that should be a very sharp upstroke and a very sharp decline. This is critical because the area under the green curve will be the denominator of the calculation of your flow. So if you miss the peak somehow because the ROI is mispositioned or misplaced, you might actually not get a very accurate input function. The second part of this is that you see the color curves correspond to the tissue in the different parts of the heart. But what you see is that at the beginning of the stress curves, you see that the beginning is not set to 0. You can see, Moaz, if you could point to the stress tissue curve, you can see that so this is not set to 0, and this is because there is residual activity from the rest injection that was done. So when you compute the flows, this residual activity has to be subtracted. All of the commercial softwares have a way to do these background subtraction, which will, if you click there, you will reset curve to 0. Can you do the background? Here, the flows are 3.7 before we do the background subtraction, the residual activity subtraction. And now when we correct that, you will see that those flows will actually come down substantially on the residual subtracted images.
So this is the uncorrected curves where you see the start is higher, and once we corrected, the software managed to lower the number down here. So uncorrected and corrected.
So again, this is the residual activity from the resting that spills into the stress. There's a lot of questions about this. So maybe there's a question about repeating the part about the peak activity. So maybe summarize a little bit on this part. Maybe people didn't quite catch it all.
Okay. So, what you want is ideally the input curve, which is the green line, should have a very sharp upstroke, which as you see here, and then should have a sharp decline, which is essentially as the activity in the blood pool comes down, you see that the tissue begins to take up the tracer. And this is the shape, this is a pattern that you should see on those images. So I think, and it is very important to understand that the peak, you should be able to capture the peak because the peak contains most of the area for the input function. You see that as the blood pool counts come down, there's not much of an area under that green curve. So the entire area is captured by the peak of the input function, which again is going to be pretty much the denominator of your flow calculation. So if you underestimate your input function, you will overestimate your flow because your denominator will be low. And I think you want to be keenly aware of that. So the shape that you see here is the kind of pattern that will define a normal time activity curve.
So it's very important to make sure that that rectangular sampling, the ROI, is where it's not abutting against the myocardium. It's kind of centered in the arterial blood pool, right, so, where where Moaz is pointing. And then that you follow this shape that you see here of the curve.
In general, we recommend not to place the arterial input function ROI inside the LV. While this may not be a problem in relatively large hearts, it will definitely be a problem in small hearts because you will have contamination of the counts in the myocardium spilling over to the LV blood pool activity. Most software allows for you to, or the automatic placement is typically at the interface between the LV and the left atrium, right around the valve, the mitral valve area, as you see in this particular scan.
If I may, I would like to add a few points here. I think that what you heard very nicely pointed out by Dr. DiCarli is basically all the steps that is required for quantitation of myocardial blood flow, regardless of the tracer that you're using. This is not what we're talking about here is not all Flurpiridaz specific. These are all points that relate to other tracers. If you're using rubidium or ammonia, you have to pay attention to all the points that Dr. DiCarli mentioned. I would say that the quality of the bolus is very important. We have to make sure that the bolus is tight enough and we start imaging before the injection. So we give a few frames so that you don't cut off the uptake in the blood flow activity. And one thing that is different slightly between rubidium and flurpiridaz is the sensitivity of the measurement to patient motion. Dr. DiCarli pointed out that you do see often in the beginning of the flow measurement that the patient may be a bit agitated and might move. But we have also noticed since we started doing flurpiridaz studies and getting into the habit of looking at frame by frame, that another phenomenon that may be responsible for motion, and that is what we had earlier, many years ago, described that upward creep of the heart. This is a situation that in the beginning, with the deep breathing of the patient, the diaphragm is in a lower location, the heart is in a lower location, and then it gradually creeps up to a different location, a higher location. And this kind of an upward creep is more evident or would influence the image quality more with flurpiridaz because of the high image quality or the highest spatial resolution of the image. And the good news is that all the three major software that are available for interpretation do have now provision for correcting for motion, this type of motion. And also all three software packages allow the residual subtraction that was pointed out that is important to remove activity from the first injection to the second injection.
Okay, well, thanks Jamshed and Marcelo for all of these important QA steps. As you know, once we've done this, now we can see that the resting flow is 0.72 with little heterogeneity in the resting flow, and we have a nice peak flow which is 2.73, and also very reassuring in this patient with a flow reserve of almost 3.81. So whichever way you look at it, we have very nice resting flow, we have very nice peak flow, and this is very reassuring normal study. This is CEDAR software, and I opened the study, and you can see here similar kind of representation of the fusion images. And Piotr, anything you want to mention about the registration here? How does it look for you?
So looking at this case here, it looks reasonable, I think.
Yeah, looks pretty
Yeah,
good.
yeah,
I totally
yeah.
agree.
And I wanted to mention, like we said, that when we quantitatively check this, anything above 5 millimeters is a problematic number. So like half of the myocardium, if it's that, then anything in that range will cause some problems.
So this should always be the first step in the hybrid imaging to look at this. So maybe I'll move on to the images. I'll show it first in color and then I'll show it in gray later on. Anyone would like to comment on this?
Well, I can just start
Sure.
by pointing out that again in this case we can see low activity in the apex that appears to be the same size, and by looking at the gated we'll see whether that actually moves, which I'm pretty sure that it does. And also you can see let's just take a look at that. So there is proper apical thinning, counts are increasing in the apex. There is thickening of that area. You can see it very nicely here. So this represents apical thinning. And also look at please follow the papillary muscle here that you can see it very nicely in the diastolic images, and that point that is actually very quite prominent. And that prominence of the papillary muscle is not an indication of left ventricular hypertrophy. This is a normal visualization. And also, please pay attention to the contraction of the right ventricle. You can see how nicely the right ventricle is visible, and you can see the contraction, as opposed to SPECT imaging, that when we see the right ventricle, we worry about right ventricular strain or pulmonary hypertension or all kinds of other right-sided disease. Visualization of the right ventricle is a quite normal phenomenon. And you can actually pay attention, close attention. You can see even the left atrium behind the left ventricle in many cases, even though it is a very, very tiny and very thin structure.
Okay. So yeah, I agree. I'm just gonna go back to show it on color so everyone has the chance to look at it again. Apical thinning. And we're gonna move now to the kinetic model. So I'm gonna go back to it's there. And again, I'm gonna run automatic motion correction for the important things that have already been discussed here. So you can see also the display of the software and here. So Marcelo, anything, or Piotr, anyone would like to comment on this in terms of flows?
This is a normal flow, and you can see the nice peak here, and you could see the motion correction. It will affect the flow. So you can kind of see this motion correction should be performed on every case. It's not an optional step because we find this is happening in many cases, and pretty much every case should be done with motion correction.
Yeah, I would like to add that the normal values for myocardial flow reserve and stress flow are different that we see with flurpiridaz as compared to rubidium. The number of stress flow and the MFR are slightly higher because of the higher extraction fraction. Now, the normal limits for what constitutes the division between normal and abnormal has been well established with all three software packages. And all of these have been published in the literature. And I encourage you to look up the three software packages that have extensively looked at flurpiridaz are the NVIDIA that you just saw with the CEDARS package, and also the Emory Toolbox package that they all have been quite well validated. One of the points that we were curious about was that what is the correlation between these three different ways of quantifying images on the same patient, and that actually is the subject of a manuscript that hopefully will come out soon. The message of that manuscript is that when you compare the three different software, there is a very close correlation between the numbers. So I think that all of these numbers are available in publication, and you can refer to them as a cutoff for abnormal flow in different areas. One other point that I want to make as we go forward is because of the higher image resolution that we have with flurpiridaz, we are now able to do flow analysis on a segmental level, meaning that instead of regions, as you see that we have 3 regions here, we can go to a 17-segment model and measure flow at each one of these 17 segments. And that has been shown by our group, Dr. Packard, that this actually provides superior information as compared to regional flow in patients. And that is something that as we go along, you will probably see some cases that if you rely on the entire territory flow, we may not see an abnormal number because it gets diluted by the normal portions of that territory. But if you go to segmental flow, you will clearly see the abnormality in that segment. So as we go forward, I'd like you to take a look at these segmental versus territorial flow numbers and how they can help.
So I think Dr. Almala, if you can see, there's a grid groups here on the top, in the blue. You could show this just a little lower. Sorry, oops, it went. You can do the segmental processing here, but we don't show the curves for each segment because it would be very
right. It would make it very complicated.
Very noisy, but so
nice. Can we show? Can we look at? All
If you see groups here in the last, like in the blue, right. You were right, almost there, like at the bottom of the blue. Like go to the bottom of this blue, lower.
Okay,
just here.
I see.
Just switch to segments here. Yeah, so you can get segments in each.
Yes.
I need to change the font on my computer to show it well. Okay, but yeah, I mean, all packages allow you to do this, and this is it's reassuring to hear that almost all of them are correlate very closely based on your work, Dr. Madahim. Okay, so another normal case we wanted to show with this software. Marcelo or Jennifer, anything else you want to add here?
No. The only clarification is that you can actually look at segmental flows with all the tracers, not just Flurpiridaz. Okay, so I think that's something that it's important to remember. And like Dr. Madahi mentioned, when you have small branches that can lead to artifacts, if you look at the entire territory, you might actually miss a flow abnormality. So you have to look for the homogeneity around those areas in the entire territory.
And in part 2, we will review several abnormal F-18 Flurpiridaz cases. Thanks for attending this session.